We know the danger here is if the plaque ruptures, forms a clot, if we put a stent in, is there still fear of a rupture? Or does that pretty much nullify it?
Basically, that plaque that you just stented, you put a bomb in there, basically. Basically, you just squashed the heck out of it into the walls. So that piece of artery where the stent is needs to repair itself. Now, this is very important. When the artery repairs from the damage that you just did with the stent, it's a process called intimal hyperplasia. It's not atherosclerosis. So what happens is that the smooth cells, which are in the wall of the muscle, they migrate into the intima and they cover over the stent. That material is called intimal hyperplasia. It transforms cells from the smooth muscles as they become intimal cells. And when you go inside and look at it with an angioscope, its characteristics are totally different. So that piece of the artery will now look white, and it'll be shiny, and it'll be very smooth. And that's called intimal hyperplasia, that's covering over that stent. So that portion is extremely unlikely to crack, because cracking occurs in atherosclerotic plaques. But there are other parts beyond the stent, before the stent, that could rupture. You see? So when you do this, when you put a stent in, the natural history of that particular portion of the stent, the artery where you put the stent, is now going to be dictated by the damage that you did. Now, let me explain. When we put stents in these days, we use drug-eluting stents. What's all that all about? Why don't we just put a regular stent in? And I'm going to explain to you why. Because when you put a regular stent in, you've damaged the wall, you've spread it out, it's going to repair itself. And the repair process, which is too much, like a keloid that grows, causes re-narrowing of that artery in that segment. And if that stent re-narrows, we call it restenosis. That restenosis is because of intimal hyperplasia. It's not due to atherosclerosis. So you could have the best lifestyle that you possibly could have. And if you've done enough damage in that area, and if your body's physiology is that it overcompensates and it covers over that stent too much, the material grows into it too much, you're going to end up with a narrowing. And it did happen in 20% of patients where you put a stent in, and then they come back 6 months later and they got a stent restenosis. Then you got to go back and do something else to it. So then what we did is we came up with drug-coated stents. So the drug-coated stents are covered on the stent. We put a chemical on it which prevents mitosis. Mitosis is cell division. I told you that the intimal cells migrate from the smooth cells. They move into the intima, they transform, and they become intimal cells. So it's cell division. They need to divide and grow. And that's what overgrows on the inside of the artery. So this drug prevents mitosis. So now there's going to be a decreased amount of intimal hyperplasia. But that's why you need to be on an antiplatelet agent for 1 year, because it takes longer now because of the inhibitory effect of that drug to cover the inner lining of the stent. Because the stent has to get covered over, usually just by a couple of cells layer of intima, that then the blood is no longer exposed to the metal. That's why you have to take the antiplatelet agents. And it can take 6 months to a year before that stent gets fully covered over. That is why after doing a stent, you have to be on antiplatelet agents. And this is a very important point you brought up, because if you don't take the antiplatelet agents, you can have a couple of struts that are still not covered over, and therefore they form blood clots on it. And I told you that part 2 of this is blood clots, and the blood clots can occur on a stent as well, just as it can on a piece of plaque that's ruptured. So you have to be on antiplatelet agents. So the intimal hyperplasia now with drug-coated stents is reduced. So when you put a drug-coated stent, the restenosis rate within that stent is less than 5%, which is wonderful news, because that means that segment has a less than 5% chance that it's going to have a problem. And if a year goes by and if it hasn't narrowed, it's unlikely to give a problem. Long term, there's a 0.001% chance that stent will be a problem. But the problem is not that. The problem is it's going to get progressive disease because we're not doing enough prevention. So another plaque is going to grow. So general rule, if I do a stent on you and you come back within a year with symptoms, it's likely I have to look at that stent. If it's more than a year, you've got a new blockage somewhere else. You have now developed new disease, de novo disease. somewhere else. Why? Because of failure of your prevention plan. Yeah. So you are still at risk of rupture, not at the site of the stent, but in another site. That's the message. That the answer to your question is, yes, you still are, but in a different segment. You see how interesting this is? It's fascinating because people think that they got a stent and I'm done. No, you're not done. No, you're not done. You got a stent. Okay, fine. That segment is now under control. What about the rest of you? That's where you're going to rupture a stent. There is a thing called edge restenosis, which is right at the edge of the stents. Because, you see, there's a cardinal rule when you're stenting that you want the edges of the stent to be in normal segments where there's not much plaque. But if the edges are still within a plaquey area, then you can get edge restenosis as well. So part of that's technical. So a good interventionist will cover the narrowing and just beyond it. So you land the ends of the stents in normal segments so that you don't get edge restenosis, because that can happen, or even rupture, as you said. But again, that's normal segments. Yeah. It's your other artery that's going to be a problem. It's the rest of the artery that's a problem. So, when a patient has a stent, they often come back to me and say, oh, yeah, but then, I know a friend who came back, and then a year later he got a second stent, and then a year later he got a third stent. And if you go back and look at the history, it's usually a new blockage. It's not a failure of the stent. It's a failure of your prevention program.
Well, this ties into what you started with, saying the fact that this is a systemic problem and inflammation's at the root of it. So a stent is a Band-Aid and there's a use for it, but we got to get to the root of why all that happened.
I love it what you said. It's a Band-Aid. A stent is a Band-Aid. Now, is it useful? Of course it is useful, because it's going to take away your symptoms, first of all. First thing you're going to get for the stent is you're going to get a relief of the pain, or you're getting relief of the ischemia. The ischemia may be silent, because remember I told you 8 out of 10 patients don't actually get the chest pain. You're relieving ischemia, and ischemia is a good thing to get rid of. But it's still a Band-Aid, because you just found something, you fixed it, but wait, the fire is still on.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
A lot of coronary artery disease is very silent. That plaque is silently sitting there in millions of people without them even knowing. And there are ways to find this out now. We have the technology. It's just not